Welcome to the image analysis of the chest. Today we will go over image analysis guidelines for chest projections of the PA lateral and decubitus chest. We'll also review common positioning errors and ways to take corrective action. Image analysis guidelines for the PA chest projection state that the thoracic vertebra and posterior ribs are seen through the heart shadow and mediastinal structures. The lung field should be demonstrated symmetrically. Distances from the vertebral column to the sternoclavicular ends should be equal. The lengths of the right and left lungs corresponding posterior ribs are equal. The mandible should not be demonstrated within the exposure field. The clavicles are positioned on the same horizontal plane. The scapula are located outside the lung field. The chest is demonstrated without foreshortening. The manubrium is positioned by the fourth thoracic superimposed by the fourth thoracic vertebra. 1 inch of the apical lung field is visible above the clavicles. The seventh thoracic vertebra is at the center of the exposure field, and both lungs from the apices to the costophrenic angles are included within the exposure field. Here are those guidelines for your review. It's important to recognize rotation on a PA projection of the chest. The reason it's important is because on a rotated PA chest projection, rotation tends to demonstrate distortion within those mediastinal structures, and it creates an uneven brightness between the lateral borders of the chest. And so therefore you want to ensure that that mid-coronal plane is parallel with the IR so that we can decrease this distortion. So how do we detect rotation? Well, it's easily detected on a PA chest projection by evaluating the distances between the vertebral column and the sternoclavicular ends, and by comparing the lengths of the posterior ribs. On a rotated PA chest, the sternoclavicular end that demonstrates the least vertebral column superimposition and the side of the chest with the greatest posterior length, rib length, represents the side of the chest that's positioned farthest away. So for example, in this projection, the right side of the right clavicle is the furthest away from the vertebral column, and the posterior ribs are elongated, which is indicative of the patient being in a LPO position with the right side farther away from the IR. Let's move on to mid-coronal plane tilting. Plane tilting tends to foreshorten the lungs and the heart, again resulting in distortion. So we must maintain that the mid-coronal plane stays parallel with the IR. So in anterior mid-coronal plane tilting, where the patient is superior mid-coronal plane is tilted towards the IR, you will see that the manubrium will be situated at the level of the fifth thoracic vertebra, or even lower, where we want it at the fourth thoracic vertebra. I'm going to scroll to the next image to show you what that looks like. In addition, you'll see that there's more than 1 inch of the apices demonstrated above the clavicles. Also, the clavicles won't always be demonstrated horizontally. You'll actually sometimes see them be demonstrated vertically. All this should indicate to you that the mid-coronal plane is tilted towards the board, and we need to get that plane parallel with the board or the IR. In posterior mid-coronal plane tilting, where the superior mid-coronal plane is tilted posteriorly, again, you're going to get those lungs and heart foreshortened, creating that distortion once again. But this time, the manubrium, which you'll see in this image here, is situated at the level above the fourth thoracic vertebra. In addition, less than 1 inch of the apices is demonstrated above the clavicles. Again, we must maintain that the mid-coronal plane is parallel with the IR to get a acceptable image. Now we'll take a second for you to evaluate this image and answer the following question. Let's do this practice analysis together. When looking at this PA chest, I want to look at my sternoclavicular ends to see if they are equidistant to the vertebral column, which they are, so there is no rotation. However, you do want to look at the position of the clavicles. And in this projection, the clavicles are seated within the apices here, okay, which is indicative of some type of plane tilting. And therefore, the manubrium is situated above that level of the fourth thoracic vertebra. It's actually sitting at the third. And this should tell you that there is some upper mid-coronal plane tilt posterior. Also, if you count the posterior ribs on the right side, you will determine that the projection was taken without full inspiration. So in order to correct this image, you need to move the upper thorax towards the IR until the mid-coronal plane is parallel with the IR, and then have the patient take in a deeper breath by making the exposure after the second full inspiration. Take your time and analyze this image, and then answer the next question. Let's review the practice analysis together. Again, I'm going to look at the sternoclavicular ends to determine if there is any rotation. Again, these clavicular ends seem to be symmetric to the vertebral column, so there is no rotation. However, next I'm going to look at the position of the manubrium and the clavicles. The clavicles have a vertical look to them as opposed to the horizontal position we like them in. Also, the manubrium is sitting at a level below the fourth thoracic vertebra. It looks more like the fifth. With this analysis, we can determine that the upper mid-coronal plane is tilted anteriorly. So how do we make the corrective action? We need to move that upper thorax away from the IR until the mid-coronal plane is parallel with the IR. Analyze this PA chest analysis practice and then answer the next question. Let's conduct the practice analysis together. The first thing I'm going to look for is rotation. So I'm going to look for those sternoclavicular ends and their relationship to the vertebral column. In this case, the right sternoclavicular end is demonstrated away from the vertebral column here. So that should indicate to you that the right side of the chest is farther away from the IR. The patient is in a LAO position. Next, you want to determine whether or not the clavicles are demonstrated horizontal in the position of them and the manubrium. And it looks like they are around the fourth thoracic vertebra, so we are good on plane tilting. The last thing, and Merrill state that in evaluation criteria, that the scapula should not be demonstrated within the lung fields, and they are demonstrated within the lung fields. So this should indicate to you that we need to take some corrective action and repeat this image. In order to correct this imaging errors, we need to rotate that right side of the chest towards the IR until the mid-coronal plane is parallel with the IR. We also want to protract the shoulders forward by placing the hands on the back of the hips and rotating those shoulders anteriorly. Let's move on to the lateral chest projection. Image analysis guidelines for the lateral chest projection state that the right and left side posterior ribs should be demonstrated nearly superimposed with no more than ½ inch of space between them. The sternum should be demonstrated in profile. The mandible should not be within the exposure field. The lungs are demonstrated without foreshortening with nearly superimposed hemodiaphragms. No humeral soft tissue should be seen superimposing the anterior lung apices. The mid-coronal plane at the level of the 7th thoracic vertebra is at the center of the exposure field. The entire lung field, including the apices, costophrenic angles, and posterior ribs, are all to be included within the exposure field. Here are those guidelines for your review. So some common positioning errors in lateral chest projection is definitely rotation. So how do we determine distinguishing rotation between the right and left lungs? Well, there's 3 methods. The first method to discerning which way the patient is rotated is to identify the hemodiaphragm with the gastric air bubble. Well, we know that the stomach lies underneath the left hemodiaphragm. So therefore, when a patient is upright, gas in the stomach will rise to the fundus. So if you see air in the stomach, you can trace that hemodiaphragm back to determine which diaphragm is posterior or anterior to the other. The next method of distinguishing the right and left lungs is to look for lung tissue that is anterior to the sternum. This lung tissue shows when the right lung is rotated anteriorly and is not demonstrated when the left lung is rotated anteriorly. The third method of distinguishing one lung from the other is using the heart shadow. Because the heart shadow is located in the left chest cavity, and it extends anteriorly and inferiorly to the left hemodiaphragm, Outlining that heart shadow enables you to recognize the left lung. So let's take a look here. This is just an example of what a patient would look like in right lung when the right lung is anterior to it in a lateral projection. But let's look at an actual image. The first thing we talked about was locating the gastric bubble. If you actually take your finger and follow the hemodiaphragm that is right above that gastric bubble, that should be the left hemodiaphragm. And so it extends posteriorly, which should indicate to you that the left side of the patient is located posterior and the right side of the patient was positioned anterior. Another clue was that lung tissue. The right lung tissue will be demonstrated anteriorly more if the right lung is positioned anteriorly. This is just an example of a left-sided of the patient being positioned anterior on a IR. Let's look at it via a actual image here. When the left lung is positioned anterior, again, you can look for gastric bubbles, but in this case, we have a lot of gastric air and air in the colon here. So that may not always work for you. The next thing you can look at is the superior heart shadow. When the heart shadow extends beyond the sternum, as it does in this case, that should let you know that the left lung is positioned anterior. It is also important to note that it is most common to see that on a rotated lateral chest projection for the left lung to be rotated anterior and the right lung to be rotated posteriorly. So let's look at distinguishing scoliosis from rotation. On a lateral chest x-ray with a patient that has scoliosis, the lung field may appear rotated, and that's because of the deviation in the vertebral column there. It's important to note that you really need to view the PA chest projection to confirm the diagnosis of the patient. Also, when distinguishing scoliosis versus rotation, the posterior ribs will be demonstrated with differing degrees of separation depending on the severity of the scoliosis. So in the first projection, you would determine that this is scoliosis because of the differing degrees of rotation. Also, the anterior ribs will still appear superimposed. So this should let you know that we have scoliosis here. It's not rotation. Whereas when rotation, you'll see that the anterior portion is not superimposed as well as the posterior portion. And again, you want to use your either the gastric bubble, the tissue anteriorly seen, or the heart shadow to determine whether or not the left or right side is positioned anterior to. And in this case, in the second image, the left side is positioned anterior to the right side. Go ahead and analyze this practice analysis and answer the following question. In our first practice analysis of the lateral chest, we want to determine if there's any rotation. And indeed, by the look of the posterior ribs, which are separated by more than that ½ inch, there is some chest rotation indicated here. utilizing our 3 cues of looking for the gastric bubble, any soft tissue or lung tissue anterior to the sternum, or the heart shadow. The lung tissue in this case is not demonstrated anterior to the sternum, so that must mean that the right side of the thorax is rotated posterior. Another key reason to repeat this image and to make some corrections here is looking at the soft tissue here in the humerus and where it is lying within the anterior portion of the apices. We need to get those arms up higher. So how do we take corrective action here? We really need to position the right side of the thorax anteriorly. The amount of movement needed to be very minimal, but we do need to correct this so that the mid coronal plane is perpendicular with the IR, and have the patient raise those arms up vertically so they can remove that soft tissue out of the anterior lung apices. Take your time to analyze this image and we will review it. First, we want to look for any rotation here in this image. And the posterior ribs seem to be superimposed, okay? Next, we want to look and see, did this patient, did we get an adequate imaging accordance to Merrill's? And looking at the hemodiaphragms, there's an exaggerated cephalic bow, and the 11th thoracic vertebra is demonstrated inferior to the hemodiaphragms. The projection was not taken on a full inspiration. So therefore, we need to take a second image and instruct the patient to take in a deeper inspiration and make sure that you expose on the second full inspiration. Let's look at this last practice analysis together. When looking for rotation, you really don't see any. The posterior ribs are adequately superimposed. However, the hemodiaphragms are not superimposed. And I think it's important to note that when you see this, you should definitely question it. Refer back to the PA projection to determine if there's any pathological conditions that are causing one hemodiaphragm to sit above the other. However, if there is not, ensure that the patient's hips are symmetrical and that whether or not you may need to reposition them so that we can get those hemodiaphragms superimposed more. Let's move on to the chest AP projection. This could be done either supine or with a portable mobile unit. For the image analysis guidelines for the AP projection, chest projection, states that the lung field should be demonstrated symmetrically. Distances from the vertebral column to the sternoclavicular end should be equal. The lengths of the right and left corresponding posterior ribs should be demonstrated as equal. The chest is demonstrated without foreshortening. The manubrium should still superimpose the 4th thoracic vertebra. There should be 1 inch of the apical lung field visible above the clavicles. Posterior ribs are demonstrated at a gentle superiorly bowed contour. The mandible should not be demonstrated within the exposure field. Clavicles are positioned on the same horizontal plane as a PA projection. The scapula are located outside the lung field when possible. The 7th thoracic vertebra should be demonstrated at the center of the exposure field. Both lungs from the apices to the costophrenic angles are included within the exposure field. All anatomic artifacts and removable leads should be removed if possible. Here are those guidelines for your review. Let's talk about the importance of central ray angulation. Central ray angulation really is important when doing supine or mobile procedures. The central ray really must be adjusted so that it is aligned perpendicular with the IR into the mid-coronal plane. Inaccurate cephalic angulation or caudal angulation of that central ray, misaligned, when misalignment with the anatomy occur, distorts the lung and heart structures. In the case of the central ray being angled too caudally, it moves the manubrium inferior to that fourth thoracic vertebra, and it demonstrates more than 1 inch of the lung apices superior to the clavicles. It also, the excessive caudal central ray angulation changes the posterior rib contour to vertical. And so when looking at this image here, you can see that we have described everything that indicates an excessive caudal central ray angulation. In excessive cephalic central ray angulation, the manubrium will be demonstrated superior to the fourth thoracic vertebra. This also demonstrates less than 1 inch of the lung apices superior to the clavicles, and again changes those posterior rib contour to a more horizontal look. Again, this angulation being inaccurate will distort the heart and lungs. So it's important to make sure that you have a perpendicular central ray. Utilizing the guidelines, analyze this image and answer the following question. When analyzing this image, you want to look at the position of your sternoclavicular ends, determine if there's any rotation, and in this case we have none because they are symmetric to the vertebral column. Next, we want to look at the position of the manubrium, and you want to look at the position of the clavicles. In this case, the clavicles and the manubrium are sitting at a position below the fifth thoracic vertebra, or around the fifth thoracic vertebra, and there's a lot of space between the apices seen above the clavicles here. This should indicate to you that the central ray was angled too caudally. Also, when counting the posterior ribs, there are only 9 with adequate lung field in front of them. So therefore, the projection was not taken on full inspiration. In order to correct this imaging, we definitely want to coax the patient into obtaining a deeper inspiration and making sure that you take the image on the second full inspiration. You also want to adjust the central ray cephalically until it's aligned perpendicular to the mid-coronal plane. Go ahead and utilize your image analysis guidelines to answer the following image analysis practice question. In this next practice analysis, again, you want to look for rotation in the relationship of the sternoclavicular ends to the vertebral column with which they are symmetric. Next, you want to look for the position of the manubrium and the clavicles. In this case, the clavicles are seen within the apices. The manubrium is above the fourth thoracic vertebra. So this should indicate to you we have a central ray angulation problem. Also, the contour of the posterior ribs are horizontal in this case. So, this should indicate to you that the central ray was angled cephalically. In order to correct this imaging error, we need to adjust the central ray angulation caudally until it is aligned perpendicular to the mid-coronal plane. Utilize your image analysis guidelines to evaluate this image and answer the next question. In this image analysis, we are going to first, again, look at the relationship of the sternoclavicular ends and to the vertebral column. And in this case, the right sternoclavicular end is demonstrated further away from the vertebral column than the left. The right side of the patient and the IR are placed closer to the bed and further from the collimator's face than the left side. Or the central ray could be angled towards that right side. Also, you want to look at the manubrium. In this case, the manubrium is inferior to the fourth thoracic vertebra. More than 1 inch of the lung apice is demonstrated above the clavicles. And looking at the posterior rib contour, it is vertical. So we have a central ray angulation here. And we may have rotation. It could be patient rotation, it could be the IR that they're leaning on it, or it could be your central ray is angulated towards that right side. But in this case, we also need to determine that the caudal central ray angulation is excessive here. And so in order to take corrective action, we need to elevate that patient's right side of the patient, or elevate the right side of the patient and the IR, or adjust the central ray towards the left of the patient until the collimator's face is parallel with the mid-coronal plane, or IR. And you want to adjust the central ray angulation cephalically until it is aligned perpendicular to the mid-coronal plane. And all these artifacts that are on this patient, if we can shift them so that they're not within the lung field, or request permission if we can remove them for the picture, would be in the patient's best interest. Lastly, here we're going to review some decubitus imaging. Image analysis guidelines are the same for the AP, PA projection, and even the decubitus position. So please review those image analysis guidelines, as we've already been over them twice. The most important thing to note is in this projection, there is a higher chance or probability of chest rotation. Typically, patients will either rotate anteriorly on their side or posteriorly, just depending on where the IR is and how the projection is being taken. It's just more of a patient comfort thing, and like I said, the biggest concern here will be looking for rotation. Utilizing our image analysis guidelines, go ahead and analyze this image and answer the following question. In this PA decubitus chest practice analysis, we're going to look for rotation. So you want to look for your sternoclavicular ends. One is about here, and the other is crossing the vertebral column. So that should indicate to you that there is some rotation here. In this case, the right sternoclavicular end is further from the vertebral column, and the right posterior ribs appear to be elongated. This should indicate to you that in the PA projection, the right thorax is positioned further away in the IR. In order to correct this imaging error, we need to rotate that patient's right side towards the IR until the mid-coronal plane is aligned parallel with the IR. Had this been a AP projection, that would mean that the right side was positioned closer to the IR, and we would have move the right side away from the IR if it was an AP projection. This concludes the image analysis of the chest. If you have any questions, please feel free to reach out.